different people look at the risks that they confront in their lives and make different decisions. We all do some things. I suspect there isn't a person in this room who doesn't do at least something from time to time that if they were just making a bet on living the longest, they wouldn't do. For example, you drive on I-95, or you ski or something like that, which can harm you. So I wouldn't say that all women should be on it, but the facts are that most of the risk that you will have accumulated in your life for getting breast cancer is already programmed into you by the time you're 50 or 55 for the reasons that Walter has already said. Your age at which your periods started, the age of your first full-term pregnancy, the lack of nursing for years and years, the age of menopause. This confers most of breast cancer lifetime risk. And so most women are looking, particularly as heart disease drops as we adopt healthier lifestyles, your risk of breast cancer gets greater each year that you live, so that as we live longer lives, your cumulative risk of breast cancer goes up. And that's why you see these numbers, 1 in 9, that kind of thing, because you're living longer and you can accumulate that kind of risk. In that setting, it is a reasonable bet if you want to reduce half of all of your breast cancer risk, and if you want to reduce the risk of osteoporotic fracture, like wrist and vertebra and hip, which is a tremendous cause of life-shortening illness in women. Tamoxifen, or better, Raloxifene, is a good bet, and I think many more women should be on it than others. When you hear about side effects, this is something I say in my practice to women. And this may sound like I'm just a male chauvinist, stupid guy, and fine, it's not true, but you can hear it that way if you wish. I say to women, don't worry about a side effect that will go away when you stop the pill. Because, first of all, many women don't have it. Many women taking tamoxifen or raloxifene cannot tell they're taking the pill versus a placebo. If you have a subjective side effect and you don't like it, so you quit, stop it, and you won't die of it. The side effect will go away. So I think a subjective side effect, the fear of getting a hot flash, is not a reason not to try something. That's my opinion about this.
The one thing that worried me about it was the risk of blood clots.
Yes.
Is that a
and it's a real risk. It's about, but it's no different from the risk of getting blood clots if you were taking Prempro or estrogens or birth control pills. It's about the same risk. It's real. It's detectable. I think that if you tend to screen women who are potentially very elderly, very infirm, very obese, very sedentary, history of varicosities, and try to take them off of your group and leave yourself with a different, you can reduce that risk substantially.
So the healthy middle-aged and older woman who's at risk is who Mark's really describing, somebody who really can get a benefit from this. I think it's worth underscoring exactly one of the points Mark made, which is that a lot of what we worry about in risk is related to the societal perception. And for reasons that are very complicated, tamoxifen was labeled a dangerous drug. In fact, in the state of California, if I'm not mistaken, it's officially listed as a carcinogen, the drug. So every time you write a prescription for tamoxifen, the patient gets a warning that they're taking a carcinogen because it can cause cancer in the uterus. But nobody ever talks to their gynecologist about not taking birth control pills because they give you the same risk of blood clots, as Mark pointed out. And there's another point to be made, is for all the concern about risk, I'm not aware of any study with tamoxifen and more recently raloxifene where the people taking it were more likely to die than the people not. Even if there's ever a trend, it always favors the treatment. And that's a very reassuring point, I think.